Welcome to Conversations on Compliance, an exploration of some key pharmacy standards and how they translate into practice. In this lecture, we will look at USP788, the standard on particulate matter in compounded intravenous drugs, the limits, the factors related to occurrence, and the clinical considerations involved. The program objectives in this lecture will be to, number one, demonstrate that parenteral drugs may contain particulate matter. 2, identify factors that contribute to the amount of particulate matter in parenteral drugs. 3, discuss particle distribution throughout the body based on size and macrophage activity. 4, identify potential harm associated with particulate matter. And finally, to review a real-world particulate reduction case study of a widely used antibiotic. Key points. Bacterial contamination is a serious concern in the use of parenteral drugs that may result in sepsis, bacteremia, morbidity, and even death. Patient care involving tubing and equipment, often related to length and frequency of use, is known to be a frequent source of contamination of hospital-acquired infection. Patient care includes ventilatory and nebulization equipment, urinary tract drainage tubes, and indwelling intravenous catheters. An early report from 1971 demonstrated IV fluids and volume control sets as a documented source of bacterial contamination. Another potential adverse effect of IV therapy involves particulate matter contaminants and intravenous drugs and solutions. It has been demonstrated that particulate matter causes infusion phlebitis, pulmonary granulomas, pulmonary artery lesions, severe pulmonary dysfunction, and even death. This is most significantly in critically ill patients who receive longer duration intravenous antibiotic therapy coupled with pre-existing dysfunction, then further complicated by particulate contamination. This is supported by the key finding in Lear's work in an animal model which demonstrated that particulate matter contaminants from different parenteral solutions jeopardizes nutritional capillary perfusion in an experimental microvascular bed compromised by prior ischemia. The timeline in which intravenous particulate matter was identified and the potential harm it could cause is an interesting progression. In the 1950s, Bruning studied 150 children who had received various amounts of parenteral fluids and observed granulomas in the pulmonary arteries in 19 cases, corresponding to a frequency of 12.67%. In 1960, 25 cases of pulmonary arterial lesions were described in autopsy specimens from premature infants who had received intravenous injections of large volumes of fluid. Garvin and Gunner identified particulates from fluids and foreign body granulomas found in patients with high volumes of IV fluids. In the 1970s and early 80s, there were a number of important publications about the adverse clinical effects of parenteral drugs. This has been updated in an article in the American Journal of Respiratory and Critical Care Medicine. In 1985, USP788 became the official set of standards for particulate matter in large and small volume parenterals. USP788 was amended in 1995 to become even more stringent, with small volume limits set at 6,000 particles at greater than or equal to 10 microns and 600 particles at greater than or equal to 25 microns. Large volume limits are 25 particles per mil at greater than or equal to 10 microns and 3 particles per mil at greater than or equal to 25 microns. These limits were originally set for small volume at less than or equal to 10,000 particles per container, greater than or equal to 10 microns, and 1,000 greater than or equal to 25 microns. Large volume limits were originally 50 per mil at greater than or equal to 10 microns and 5 per mil at greater than or equal to 25 microns. Key points. Particulate matter consists of mobile, randomly sourced extraneous substances that cannot be quantified by chemical analysis due to the small amount of material that it represents. Injectable solutions, including solutions constituted from sterile solids intended for parenteral use, should be essentially free from particulate matter that can be observed on visual inspection. The injection meets the requirements of the test if the number of particles present, actual or calculated, in each discrete unit tested or in each pooled sample tested does not exceed the appropriate value. The microscopic particulate matter test may be applied to both large volume and small volume injections. This test enumerates subvisible, essentially solid particulate matter and these products on a per volume or per container basis after collection on a microporous membrane filter. Some articles cannot be tested meaningfully by light obscuration. In such cases, individual monographs specify only this microscopic assay. Solutions exempted from analysis using the microscopic assay are identified on a monograph basis. Standards for particulate matter became official in 1985 with the recognition that intravenous fluid should be free of visible particles. The standards for small volume parenterals in the mid-1980s were that particulates should not exceed 10,000 particles greater than or equal to 10 microns and 1,000 particles greater than or equal to 25 microns per container. The 1985 data used by USP to set particulate limits were actually based on combined data in small and large volume parenterals and were presented as counts per mil as opposed to the current small volume parenteral counts per container. In 1995, particulate matter standards were changed. The standards in effect today are the same standards used in 1995. A stimuli article from the microbiology team of the Office of Generic Drugs of FDA was published in 2004. Its purpose was to generate discussion about the need and usefulness of tighter limits. Particulates occur in all solutions. The quantity and size vary with each solution. This study demonstrates 6 different solutions and the mean distribution by size of particle. The solutions studied were dextrose 5% and 0.2% sodium chloride. This was the base solution. A base solution containing 20 milliequivalents of potassium chloride per liter. A base solution containing 20 milliequivalents of potassium chloride and 2 mLs of vitamin B complex per liter. A base solution containing 20 milliequivalents of potassium chloride and 5 million units of potassium penicillin G per liter. A base solution containing 20 milliequivalents of potassium chloride and from an in-line medication chamber, 1 gram of citalophen sodium was delivered in a 100 ml volume per liter. Base solution containing 30 milliequivalents of potassium chloride and from an in-line medication chamber, 3 million units of penicillin G was delivered every 4 hours and 80 milligrams of gentamicin sulfate was delivered every 8 hours. The USP788 guidelines address both size and quantity. It is important to remember that there is a quantified threshold for acceptable particulate limits in both large and small volume solutions. Although variability ran as high as 30% in some cases, the simulation did allow for a fair estimate of the particulate levels in commonly used intravenous fluids. The values obtained indicate that a patient receiving IV therapy, including antibiotics, can receive approximately 34,000 particles per liter greater than 5 microns, 14,000 particles per liter greater than 10 microns, and 500 particles per liter greater than 25 microns. While the graph of the plot points above clearly indicates that all of these amounts fall within the standard for particulate matter and infusion fluids, there is evidence that particulate infusion has a systemic impact on the postoperative patient. A significant increase in white blood cell count and a marginally significant increase in erythromyce sedimentation rate were observed in patients receiving non-filtered fluids. This study data was obtained in an animal model. The size of the particle determines where they will end up following IV administration. This study is a summary of 2 decades worth of research done at the University of Kentucky on particulates and is representative of what is seen clinically in case reports of death due to excessive particulate matter. Following injection, smaller particles, in this case 3.4 microns, are phagocytized and carried to the liver and the spleen. Only 12% of these smaller particles remained in the lung. Larger particles in this animal model 7.4 and 11.6 micron particles are too large to be phagocytized, with 92 and 93% respectively stopping in the lung following injection. Phagocytosis is much less efficient as particulates increase in size. Particulates that cannot be phagocytized, in this case the 11.6 micron particles, are permanently localized in the lungs. This study, conducted in animals, concludes that intravenous administration of particulate matter may be associated with significant acute hemodynamic deterioration. This animal model analysis demonstrates a very clear tendency of the microspheres to distribute in a very size-dependent, organ-specific pattern, which is critical in understanding the presumed mechanism of harm. This study demonstrates that intravenous administration of particulate matter may be associated with significant acute hemodynamic deterioration and reveals that very small microspheres have a different distribution fate and time course than larger microspheres. The presumed pathomechanisms of harm from particulates as demonstrated in an animal model include the mechanical blockage of small caliber arterioles and capillaries by large particles exceeding in size the inner luminal diameter of the microvessels, the activation of platelets and our neutrophils with the subsequent generation of occlusive microthrombi, indirect effects on vasomotor activity demonstrated through extensive work in animal models. Here is a gross section of a normal lung, which points out looking directly down into a pulmonary artery. This image illustrates the actual pulmonary microvasculature and its filter-like activity. A number of the branches end up as dead-end tracts, and this is the reason that the lungs filter out these larger particles. Again, this is a presumed mechanism of harm. Despite the unanimous recognition of particulate matter contamination as a potential hazard, definitive proof from controlled clinical studies in humans cannot be obtained for obvious ethical reasons. To elaborate, there is potential for harm when particulate matter is injected. It is just a fact that every time an intravenous drug or solution is given to a patient, there is a finite amount of particulate matter conveyed along with the drug and the solution that is given. These are unintended particles, but it's virtually impossible to get them out of pharmaceutical products intended for parenteral use. USP788 addresses particulate matter in parenteral drugs. In practice, low levels of contamination with non-visible particles remain inevitable. The generation of particulate matter is influenced by the number of manipulations and techniques, particle distribution throughout the body based on their size, and the potential for engulfment by macrophages. If given enough particles, potential harm can occur. This has been demonstrated in humans and in animal models. Reducing and eliminating particulate contamination remains a goal for all sterile drug products. This next section will put into practice some of the principles that we have just discussed regarding particulate matter, and will bring into the discussion the variables that can affect the particulate levels of the final solutions. This case study looks at the chronology of events that led to the reformulation of Zosyn, piperacillin tazobactam. Routine product surveillance at Wyeth indicated sporadic occurrences of excessive levels of subvisible particulate matter in various admixture systems commonly used in clinical practice. Wyeth began analyzing root cause for variation in particulate formation. In the interim, Wyeth made adjustments to meet the USP788 standards for particulate formation, which included removing silicone from the rubber stoppers and shortening the expiration date from 36 months to 24 months. However, products still sporadically failed particulate testing. The following reactions demonstrate the mechanism of particulate formation of formerly available Zosyn, piperacillin tazobactam, elucidated during the root cause analysis. The molecules formed when exposed to traces of acid are much less soluble and therefore likely contribute to particulate formation. Reformulated Zosyn is tolerant to these conditions present in commercial diluents. Metal ions serve to stabilize the ring opening shown in the second reaction, thereby enhancing the reaction. Because zinc ions are catalysts for the second reaction on this slide, they are not used up in the reaction. Therefore, they remain available to continuously catalyze this reaction. The stability of a solution is affected by both pH and metal ions. Low pH of commercial diluents decreases solubility and increases particulates. The chemical degradation of piperacillin results in a potential loss of potency and an increase in drug-related degradation products, which contributes to particulates. The low pH enhances the capacity to extract metal ions from contact surfaces, including the tubing, the bags, septa, the rubber stoppers, and so forth. Metal ions, particularly zinc ions, enhance the beta-lactam ring opening of piperacillin, which in turn leads to increased dimer formation. These dimers are largely insoluble and thus contribute to particulates. During the analysis, Wyeth looked at a large number of commercially available diluents and found that there is natural variation in pH in common diluent solutions that are used for the reconstitution of injectable drugs. The diluent pH ranges vary from 5% dextrose injection, which can be as low as 3.5, or as high as 6.5, all the way up to more neutral solutions such as lactated Ringer's injection. The level of zinc is variable in commonly used diluents, both inter and intra-batch, as shown here by the sampling. Figure 1 examines zinc levels detected in 0.9% sodium chloride, revealing a wide variety in parts per million of zinc that ranges from a low of about 0.01 parts per million to greater than 0.7 parts per million. Figure 2 shows the zinc levels detected in 5% dextrose injection, again all from the same manufacturer, and the variance is again 0.1 parts per million all the way up to 0.8 parts per million. Case in point, varying zinc levels are present in virtually all IV solutions that are currently on the market. There are variable levels of zinc in commonly used diluents. High zinc in a low pH environment may result in incompatibility, which will produce an undesirable load of degradation products and an excessive number of particulates. Formerly available Zosyn was determined to not consistently meet USP788 particulate standards because of variation in metal ions and pH of commercial admixture diluents. Reformulated Zosyn has an added citrate buffer to control pH. Reformulated Zosyn has EDTA, which is a chelating agent that removes transition metal ions. Reformulation of Zosyn addresses particulate formation that results from uncontrollable variations in pH and metal ion content of commercial admixture diluents. This study was conducted to verify that citrate and EDTA, when combined with Zosyn, piperacillin tazobactam, would reduce particulate formation. In this study, IV bags were assayed for zinc. High concentration bags contain 0.59 parts per million of zinc, and the results shown are greater than or equal to 10 micron particles at 24 hours. The comparative particulate matter levels differ significantly between the Zosyn formulations. Formerly available Zosyn demonstrates significantly higher particulate matter at 7,600 10-micron particulates, while reformulated Zosyn demonstrates only 700 10-micron particles at the 24-hour mark in high zinc concentrations. Both formulations of Zosyn were tested for compatibility in meeting particulate standards when reconstituted with lactated Ringer solution by measuring total other related compounds, or TORC, which are unspecified degradation products. Formerly available Zosyn measured at an average of 6.345% at room temperature at day 1 TORC, as compared to 0.00% TORC measured in the reformulated Zosyn test. Formerly available Zosyn did not pass the standards for particulates as illustrated here. The U.S. degradant limit is 5% TORC. Based on these findings, formerly available Zosyn is not compatible with lactated Ringer's solution. Reformulated Zosyn, piperacillin and tazobactam, seen here at 0.00% TORC, is compatible with lactated Ringer's solution. Reformulated Zosyn has fewer unspecified degradation products after 24 hours. Comparing both formulations with respect to the USP degradant limit demonstrates a difference in TORC or degradation products that are in the solution. In this table, it has been demonstrated in reconstituted lactated Ringer's solution. Reformulated Zosyn, piperacillin and tazobactam, has increased compatibility with aminoglycosides. The concentration ranges in this table are based on administration of the aminoglycoside in divided doses, 10 to 15 milligrams per kilogram per day in 2 daily doses for amikacin, and 3 to 5 milligrams per kilogram per day in 3 daily doses for gentamicin. Administration of amikacin or gentamicin in a single daily dose or in doses exceeding those stated above via Y-site with Zosyn, piperacillin and tazobactam containing EDTA has not been evaluated. See full prescribing information for each aminoglycoside for complete dosage and administration instructions. Zosyn 3.375 grams per 50 ml Galaxy bags are not compatible with gentamicin for co-administration via a Y-site due to higher concentrations of piperacillin and tazobactam. The Zosyn diluent volume of standard and pharmacy bulk vials is 50 ml, 100 ml, and 150 ml with amikacin and 100 ml and 150 ml with gentamicin. The diluent volume is not applicable for Galaxy bags. Key points. The reformulation of Zosyn, piperacillin and tazobactam achieved measurable, continuous quality improvement in conforming to USP788. Decreased particulate formation was achieved because the new formulation is now tolerant to variability in pH of commercial diluents used in the clinical setting. Reformulated Zosyn now inhibits the chemical degradation and particulate formation catalyzed by the presence of exogenous metal ion contamination encountered in the clinical setting, which affects particulate formation. Reformulated Zosyn has expanded compatibility with amikacin and gentamicin, which were previously incompatible. Reformulated Zosyn can now be co-administered under certain conditions with lactated Ringer's and extensively used IV solution, whereas formerly available Zosyn was shown to be incompatible due to exceeding U.S. limits for TORC. Zosyn, piperacillin and tazobactam is indicated for nosocomial pneumonia, moderate to severe, caused by piperacillin-resistant beta-lactamase-producing strains of Staphylococcus aureus and by piperacillin tazobactam-susceptible Acinetobacter baumannii, Haemophilus influenza, Klebsiella pneumonia, and Pseudomonas aeruginosa. Nosocomial pneumonia caused by Pseudomonas aeruginosa should be treated in combination with an aminoglycoside. Initial presumptive treatment of patients with nosocomial pneumonia should start with Zosyn at a dosage of 4.5 grams every 6 hours plus an aminoglycoside. If Pseudomonas aeruginosa is not isolated, the aminoglycoside may be discontinued at the discretion of the treating physician. Infections caused by piperacillin-susceptible organisms, for which piperacillin has been shown to be effective, are also amenable to Zosyn treatment due to its piperacillin content. However, before prescribing, please consult the full prescribing information. Zosyn, piperacillin and tazobactam is not compatible with tobramycin for simultaneous co-administration via Y-site infusion. Compatibility of Zosyn with other aminoglycosides has not been established. Only the concentrations and diluents for amikacin or gentamicin with the dosages of Zosyn listed herein have been established as compatible for co-administration via Y-site infusion. Simultaneous co-administration via Y-site infusion in any manner other than listed herein may result in inactivation of the aminoglycoside by Zosyn. Zosyn is contraindicated in patients with a history of allergic reactions to any of the penicillins, cephalosporins, or beta-lactamase inhibitors. Careful inquiry should be made concerning previous hypersensitivity reactions, as serious and occasionally fatal anaphylactoid reactions, including shock, have been reported in patients receiving therapy with penicillins, including Zosyn. The most commonly reported adverse events in clinical trials of Zosyn, 4.5 grams every 6 hours, plus an aminoglycoside, include diarrhea, 17.6%, fever, 2.7%, vomiting, 2.7%, urinary tract infections, 2.7%, and rash, 2.3%.